Welcome to the ACO Show, podcast about the American healthcare system and some of the people who are working to make it better. I'm Sean Cavanaugh, joined by my co-host, Dr. Josh Israel. Welcome, Josh.
Thank you, Sean. Glad to be with you once again.
Today, Josh, we had on Halle Tecco to talk about a book she just wrote. Why did we choose this book and this guest?
Yes, Halle Tecco's new book, Massively Better Healthcare, is a take on some ways to improve the healthcare system. She talks a lot about alignment and the importance of that to improving the system, something near and dear to Aledade's heart. And we're also in the book, so that's part of how we made the connection.
It's always a good reason to read a book. But the other reason I was intrigued is Halle's background. She's an educator, taught at some of the more prestigious business schools like Columbia and Harvard. But probably most relevant, she's been a founder entrepreneur and has started companies that try to make healthcare better directly. So that's what intrigued me about having her on.
Well, enough from us. Let's take a listen to Halle Tecco. We are happy to welcome our guest, Halle Tecco, the author of the new book, Massively Better Healthcare. Welcome, Halle.
Hi, thanks for having me.
Halle, you have a background as an entrepreneur, podcaster, an educator. What prompted you to write a book?
Yeah, I have always wanted to write a book. I love writing. So I, have been in this space for a while and felt like after 15 years working in digital health, I had enough stories. I had the will, I had the time, and I had the publisher. So that all kind of came together.
Subtitle of your book is Innovator's Guide to Tackling Healthcare's Biggest Challenges.
Yeah.
So based on that background, what did you see as the biggest challenges?
Yeah. So, and I specifically said innovator versus entrepreneur because I think you can be an innovator in many different types of roles. Entrepreneurs obviously have to innovate, but there are folks that are innovating in a lot of scenarios. So really wanted to have a title that represented what I was trying to get through to the audience. So what makes healthcare challenging? Is that what the question was?
What did you see as the challenges that need tackling?
Oh, you know what? I actually don't, in the book, I don't go into that specifically because I really think that people, the best problems to work on are the ones that are keeping you up at night. The one that you are just so obsessed with solving and will wake up every day with an eagerness to help solve that problem. That to me, that's the best way to start. People who are kind of like just looking for opportunities and, land on something random, I think it's less likely that they'll have the sort of passion and endurance that's necessary in starting a company, which is something that's really hard to do. And so having that like North Star for yourself, whether, that's working in a disease area, something that you faced as a patient or a loved one has faced, that's always a good place to start. Or something that just like really frustrates you about the healthcare system that you've experienced. So I would say, start where you have the most passion to solve that problem.
One of the things you argue in the book is that healthcare is not really going to improve at scale unless a company's mission and margin are aligned. Or I guess the whole system is not aligned. Can you say more what you mean about that?
Yeah. So there are 4 rules in my book, and that's the first rule, which is align the margin and the mission. And the core idea is that healthcare only improves at scale when the way that your organization makes money reinforces and doesn't undermine your mission. And that mission could be improving access, lowering costs, improving the patient experience, the provider experience, or outcomes. And those are kind of the full set of goals in what we call and what you probably know as the quadruple aim of healthcare. Ultimately, there are many ways to build profitable businesses in healthcare that actually make the healthcare system worse. So what I argue in the book is that you start mission as the North Star, be explicit about what you are trying to improve, and then design your business model so that you do better financially and you're paid the more that you achieve your mission. And so when the mission and the margin are aligned in that way, success compounds in the right direction.
Give us some examples that you found where mission and margin were well aligned.
Yeah. So, I can tell you the example that I give for where it's not aligned And this is something that I experienced was in fertility care. So I faced infertility. I have a 8.5-year-old son now through IVF, thankfully. But I argue that actually the most profitable patients for IVF clinics are those who are not successful and those who take many, many treatments, very expensive treatments in order to get pregnant. And the least profitable patients are the ones who can get pregnant relatively quickly with little intervention. And so when you think about models like that, I'm sure that my fertility doctor deep in his heart wanted me to get pregnant. But the fact is I went through many, many rounds of IVF before we were successful, and you made more money because of that. And so thinking about mechanisms, pricing mechanisms, guarantees, et cetera, that we can layer into these business models to ensure that the outcomes for the patients are aligned. And we are starting to see that in fertility care now, fortunately, because it is quite predictive. Knowing certain biomarkers with a couple, you can kind of predict how many rounds it will take, how many eggs will be retrieved, the success rate that's likely, and it's very predictive. So now we have this data that some clinics are starting to offer like all-in prices. They'll say, we think it's probably going to take you 2 or 3 rounds to get pregnant. You pay this flat fee. You'll do those 2 or 3 rounds. And then, if you have a baby, great. If you don't, you'll get your money back. And so I think that's in the right direction because that aligns their incentives and their success with the patient's success.
Immediately reminded of just how complex the healthcare system is and the way incentives matter.
Yes.
I could see a system like that leading clinics to only choose the patients who are most likely to conceive, and then you have a whole other set of problems.
Yeah, sure. And actually we have seen that in fertility care because all of the data needs to be reported to SART, which is a program within the CDC. So outcomes data at fertility clinics is collected and distributed. And so there has been some chatter around like, are clinics turning down patients that will make their numbers look worse because they're not likely to conceive. But I think that the conversation needs to be, if a patient comes in and they're very unlikely to conceive, there are other options and they can help you with those options. Maybe that's egg donation, maybe that's surrogacy. There's usually a way at the end of the day, and you can put a price on it. You can put a predictive number on it, and that kind of de-risks it for the patient. I mean, at the end of the day, fertility clinics have way more money and power over the outcomes than a patient does. So to put that burden and risk on the patient is really unfair in my mind.
That was an example where you found a misalignment, but it sounds like you took it as an opportunity to build alignment.
Yeah.
What are the other examples of alignment that you found in your book?
Yeah. One of the cases that I do around organizations that have aligned it from the beginning is Omada Health. But what Omada Health did was they built a program around prediabetes and to support patients who were recently diagnosed with prediabetes and help them to prevent that from turning into full diabetes. And so they have a virtual care program that they built. And what they did was they created, what they did was they had to get a CPT code to get reimbursed for prediabetes care, which they successfully did. But then they built out their risk model so that when they were pitching to employers and health plans to adopt the program for their members, they said, we're actually only going to we only want to get paid if your members meet some sort of metric that we'll decide together, whether that's A1C levels, whether that's weight loss, and we won't get paid otherwise. So that their product team, their sales team, everybody is aligned with making sure that the product works. In the traditional model, which is per employee per month, you really don't have that same incentive. And the product actually becomes the product team isn't doing their job well if they're getting people in it and it's costing them money to use it, but people aren't succeeding in that weight loss. So the incentives are kind of misaligned in the per employee per month model. And so I think that's a great example. And they've been obviously very successful, and so have their patients because they're only getting paid to help them achieve their goals.
Aledade, the company for which Sean and I both work, made its way into your book.
Yes.
Alignment is really at the heart of our business model, trying to align the best outcome for patients, the best way to practice for doctors, with the best financial outcome. How did we make our way to you?
Yeah. So, writing a book takes a very long time, as you can imagine. And I was very intentional about picking case studies, examples of companies that I felt confident would still be around and relevant by the time it came out. I didn't want to have any examples where I would be embarrassed by having the company as a case study. I had been following Aledade for a while. Farzad's been on my podcast, has been kind of just on my radar for interesting companies. And I knew that Aledade is built on the very durable idea of aligning incentives in primary care. And the company is not dependent on a single trend or technology. It's really about fixing that underlying business model and giving clinicians new tools. But I think that focus on primary care, which I talk a lot about in my book, that's one of the highest leverage places to improve outcomes and costs in healthcare. So it also helps tell that story, which I think is a helpful reminder that companies, in healthcare, they have to get the fundamentals right.
In preparation for this, I was reading a lot about you, and I found one reference that called you digital healthcare's biggest cheerleader.
Yes.
When you're tackling the biggest challenges in healthcare, why is a digital approach, I assume this is your thesis, an important component of it, as opposed to just optimizing the service side of healthcare?
Yeah. Well, I think that you can do both. I think sometimes optimizing the service piece is leveraging all the tools that we have today. And we're really lucky that we're living in 2026 in many ways because we have tools like machine learning and AI that didn't exist in our field, 10 years ago. And so things are possible now that we couldn't have even dreamt of before. So I think technology is not always the answer, but it's often the answer. And I think using the tools that we have and that we're lucky to have in our space is almost like our duty as healthcare providers to ensure that we're doing everything we can to improve outcomes, to lower costs, and that includes leveraging technology in a lot of new ways.
Someone who is featured in your book, Dr. Darrin Menard. He's been a guest on our show. He's a fantastic family physician in Scott, Louisiana. Can you talk about what you learned about his practice?
Yeah. So Dr. Menard, as you said, he's a primary care physician in rural Scott, Louisiana, whose practice joined Aledade, which meant they started taking on more accountability for patient outcomes. And I loved learning about this story and talking to him. One of the first things they looked at was hypertension or high blood pressure, which is an incredibly common and major driver of heart disease. So really good biomarker to start with. And his team initially assumed that they were doing a pretty good job helping their patients manage hypertension. But when they actually looked at the data that they were able to get through Aledade, only about 63% of their patients had their blood pressure under control. And that level of visibility really changed everything for their practice. They started doing really simple things like proactively calling patients back in and adjusting medications, following up more closely. And through this transparency and through these tools that Aledade was able to give them, over time, they got their control rates over 90%. And so I actually included this case in the chapter on patient engagement, what I call healthcare sleeping giant. And the core idea in that chapter is that one of the biggest opportunities, the biggest stakeholders in healthcare is our patients, and actually engaging patients and making sure they don't fall through the cracks is one of the biggest opportunities that we have. And what Aledade did was they give practices tools to identify and reach patients who weren't coming in or weren't actively managing their conditions or didn't know that they weren't actively managing them, and then engaging them. And once those patients are brought back into care, we're seeing that outcomes improve dramatically. So kind of a bigger takeaway is that a huge amount of value in healthcare can come from just better engagement. And we can't just put that all on the shoulders of patients. There's a role for clinicians there. And let's say, we often know what to do, in theory, but the challenge is that we're not necessarily able to identify the right patients and make sure that what is supposed to be done actually happens consistently.
Yeah, and I just add, that change from 63 to 95, it's not just a number. Dr. Menard has said that he noticed just a huge decrease in heart attacks, strokes, other cardiovascular events after they did that.
And interestingly, what made that possible is a government program, the Medicare Shared Savings Program. The reason he can reorient his practice and that we support him in doing it is because Medicare has made a business case, as you say, has helped us align his margin and his mission through the Medicare Shared Savings Program. So the latest thing out of CMS that attempts to do the same thing, which align margin and mission, and is linked to digital health, is the new access model from the Innovation Center at CMS. Have you had a chance to look at this, and do you have any thoughts on that?
Yeah, I've been following along. Obviously, it's something that is going to impact a lot of the companies that I work with. So I think in general, CMS has over the years just been an incredible laboratory for new payment models, alternative payment models in healthcare. And I think we have to consider that this is the first version of something that hopefully will be really great and impactful. I think the sentiment that I'm hearing from founders is that the prices are just too low. And for human care, it's going to be really challenging for tech-enabled services companies to deliver care sustainably at the prices that they're offering. However, the question is are they expecting more AI-driven delivery care models to emerge because of this? Are they open to increasing the prices, the reimbursement rates? And I think those are kind of the open questions that a lot of the founders that I work with have. I'm optimistic about it, and I'm happy to see embracing digital health as a augment to care. And to me, I'm still optimistic about it, but just a lot of open questions still.
Well, as you're talking about digital health, that may be the answer to this question. But we've been talking about how healthcare systems, payers, groups like Aledade can improve the system. There are other important people, actors in the system. And I wonder what your thoughts are on how they can make change to make a massively better healthcare system. Let's start with doctors. What can an independent primary care physician do?
So first off, I will point out that the AMA, the American Medical Association, ranks as one of the top lobbying spenders in the US. So if I were a physician, I would make sure that they are representing my voice in DC as they advocate on health issues. I think that's just number one. You're paying dues to this organization. They're a top lobbyist. Make sure that you agree with what they're doing and what they're standing for. And if you don't, then make sure that they know. The second thing I would say, it's 2026 and I can't talk about digital health without talking about AI because things are changing really quickly. And I would say probably another really important thing that clinicians can do right now is recognize that patients are using AI, whether you like it or not. I know a lot of clinicians are understandably worried about it and their instinct is to not use it. But the reality is the ship has already sailed and tens of millions of people are already using ChatGPT every day to look up health information. And so if I were a clinician, I would make sure that I understand these tools, I'm using them, and advocate for the safe and accurate use of AI in healthcare. Instead of just ignoring it and hoping that it goes away, Dr. Google never went away and Dr. ChatGPT is also going nowhere. But clinicians do have a voice and a really important position to advocate for their safe use. And it's going to be a major part in how patients engage with healthcare going forward. And I think clinicians should be eager to be part of the conversation instead of just writing it off.
So your book is full of examples of successful alignment and real change. What's keeping us from getting more change at larger scale faster?
I think, look, if you would have told me 10 years ago that we would have a weekly weight loss shot that I could order over the internet and have delivered directly to my door, and that I could get a full whole genome sequence for under $200, down from over $1 million a decade ago, I would not have believed you. I do think that we've made an incredible amount of progress and we've seen so much innovation in the last 10, 20 years that it feels slow, but actually I think we've come a really long way. And I think that the pace of change is even speeding up right now. That said, I think that the biggest challenge and the biggest blocker for innovators are the incumbents. And healthcare has a number of very large organizations that have a ton of power and exercise what I would consider anti-competitive behaviors. They are influential because of their position, and they lobby in DC to keep the position that they're in. And I think that those large players are just need to be put in check. And if they were, then I think it would be easier for innovation to disseminate in a system that's a free market. But we really don't have that at the highest levels in healthcare.
I mean, many people have tried to improve the healthcare system and not succeeded. As you've noted, there are a lot of groups out there with a lot of power who are basically trying to implement massively better rent seeking.
Yeah, massively better rent seeking. Oh.
But your book is ultimately hopeful. So what are some things you're hopeful about?
Again, going back to the chapter that Aledade is in, I think we have a lot of signs that we've reached a tipping point. We've reached a tipping point on costs for sure. And that has really triggered patients to be more aware, more angry, more vocal, and demanding for change. And we are starting to see that. I mean, the fact that we're now having conversations around the fact that we're paying more for prescription drugs than other high-income nations, even though a lot of our tax dollars are going to the basic research that enables these drugs to come to market to begin with, and that everyday Americans are having these conversations and bringing them up, and administrators are starting to think about policies to solve that, to me, makes me very hopeful, because I think when patients and consumers are left out of the conversation and we don't speak up because we don't understand what's going on, then nothing's going to change, because then the only people that have, the ears of Washington are going to be the lobbyists of the large incumbents. But now we're starting to see this patient uprising. And even when I was writing this book, we saw a number of employees that were suing their employers for breaching their fiduciary duty of health spending and overspending on things. And so seeing that level of sophistication of consumers, to me, makes me very hopeful that change is possible now.
It's interesting when you started talking about consumers, reminded me to a question we talked about a few minutes ago, which is the access model, because those are really consumer-facing technologies. And as you said, there's questions about whether CMS designed this right. Did they get the payment right? But the real question to me is, can these new digital technologies get the consumer to do something different and better on his or her own behalf? And I know there's a lot of cool stuff out there, but none of them have been studied with the rigor that I think CMS will bring to this model.
Exactly. Yeah, I mean, it's one thing for a digital health startup to share their own data, and it's another thing to have validated third-party data on outcomes. So,
Halle, as I mentioned earlier, the subtitle of your book is The Innovator's Guide, and it reminded me my time in government. A little known fact is CMS has an Innovator's Guide to CMS. I've never met an innovator like you in the field who's heard of the document. Have you?
No, have not.
Believe it or not, it's full of useful information. I'm sure the name's been changed at this point. But thank you so much for coming and talking about your Innovator's Guide, which I think will be much more widely read.
I hope so. Thank you.